morning. I'm Dr. Benny Negalur. I'm a diabetologist and metabolic physician from Mumbai, India. And I have with me the Vice President of the European Association of the Study of Diabetes, Dr. Chantal Mathieu. She's from Belgium. She's an endocrinologist and professor of medicine at the Leuven University in Belgium. And ma'am, I'm really enjoying the sessions at this conference. I have a few questions to ask you. We know that metformin is the first line treatment in the guideline and in the management of type 2 diabetes. But now its position is being threatened with the newer drugs, the SGLT2 inhibitors. And why it is happening is that these cardiologists are using the drug and they say the efficacy of the MACE reduction is much decreased when metformin is simultaneously used with the SGLT2. Probably because they share the same mechanism of action through the AMP kinase pathway, although the SGLT2 have a certain pathway as well. And this is reducing the efficacy. So we are all in a mix-up now. What are your thoughts on this, ma'am?
Thank you very much for this question, because it needs to be clarified. Let me first of all tell you, there's no competition between metformin and any other glucose-lowering agent. I invite you all to go to Diabetologia, where you will find the publication of our consensus, ADA ESD Consensus 2022, on the management of hyperglycemia in people with type 2 diabetes. What is central there is that we now say and state, on the basis of the evidence, that we need to have independent attention to direct cardiorenal protective effects of agents, to glucose management, and to weight management. And all of them are equally important. And so when it comes to glucose management, we acknowledge that healthy lifestyle behaviors, intensive education, structured education of people with type 2 diabetes, and metformin are important for glucose management. What we do state is that if you have heart failure, if you have chronic kidney disease, if you have atherosclerotic disease or a high risk of ASCVD, that then you should also have an SGLT2 inhibitor or a GLP-1 receptor agonist on board with proven cardiorenal benefits. But so in most patients, as you will agree, we will need more than just an SGLT2 inhibitor or a GLP-1 receptor agonist to keep glucose under control for the rest of the life of the people living with type 2 diabetes. So in many patients, you will need the combination of an SGLT2 inhibitor, a GLP-1 receptor agonist, metformin. Metformin is still a very potent, cheap, affordable glucose-lowering therapy. Together with healthy lifestyle, in many people, will help you to control glucose. And so if you have individuals who do not have heart failure, do not have chronic kidney disease or atherosclerotic cardiovascular disease or the high risk, and you just need glucose management, then metformin still remains the first pharmacotherapy we want to use in individuals with type 2 diabetes. But we also acknowledge that in many, metformin will not be enough. And so when you have a high glucose level, or when you have a person at young age with type 2 diabetes, consider early combination therapy of metformin and other glucose-lowering agents. So there is no competition between metformin and other agents. And if the cardiologists say that, then they don't know the pathophysiology of type 2 diabetes. So please, yes, there is a high cardiorenal risk in individuals with type 2 diabetes, but glucose control is also very important, and metformin is still a very good agent.
I agree with you totally, ma'am, because metformin addresses the pathophysiology of type 2 diabetes, and we require it on board for most of our patients of type 2 diabetes, whichever new drug comes into the market. We'll switch on to insulin. We know this is the 100th year of the discovery of insulin, and so many new insulins have evolved over these 100 years. We are having ultra rapid acting insulin, and we are having long acting insulin, basal insulins, and we just heard yesterday the newer insulins, which are once a week insulin icodec, etc., which will be there in the future. So in spite of all these benefits, there are still barriers in the use of insulin, and especially so in my country, India, insulin is underused. What are your thoughts on this, ma'am?
What is very important when we clinicians treat people with type 2 diabetes is that we cannot use any excuse to avoid good glycemic control in people with type 2 diabetes. I hear very often the excuse that insulin analogs are too expensive, thus I cannot use insulin. That's not correct. We can still use human insulin. We can still use NPH to initiate a basal insulin if you accompany it with intensive diabetes education. It is better than to say, if I cannot use an analog, I will not give insulin. So please, let not be economic reasons be a reason of therapeutic inertia. If you can only use for economic reasons the human insulins, use them, but intensify your diabetes education. Of course, the insulin analogs are better when it comes to avoiding hypoglycemia for the same glycemic control. But please do not be inert in your therapy because of economic reasons.
It's not only for economic reasons, ma'am, because nobody wants to take an injection actually in our country, and they come and tell you, please take my insulin off and put me on the OHAs. But it is hard. If they require an insulin, they require it. So it takes a lot of time to motivate them, and we have a lot of barriers yet. I'm sure you all are doing better in your country, but it's hard in our country. So we go to the last question, ma'am. So much is spoken on remission of diabetes and reversal of diabetes, but we are getting re-reversal, we are getting exacerbation, and then we have to use the drug again to revert them back into remission. Today, I heard a very beautiful lecture on post-bariatric surgery and how many years it takes for them to get back to type 2 diabetes, and it's pretty fast. Depends on the first 2 years of their life. So we want to achieve remission in our patients. How do we go about that?
Can I just first of all say that we do not have a cure for type 2 diabetes at this moment. So whatever we call the situation of normoglycemia induced by a therapy, like metabolic surgery, like any of the potent glucose-lowering agents, it is just a situation of normoglycemia in an individual where type 2 diabetes is still there in the background. It's not because your patient, the person sitting in front of you, has had metabolic surgery and now has normoglycemia, that the complications of type 2 diabetes are not there. The vessel affectation by the years of type 2 diabetes before will still happen. I see so many people with bariatric surgery losing their feet because they get the message. After bariatric surgery, you are cured. You are not cured. You have now normoglycemia with a different treatment, namely the re-derivation of your intestine. And so we as clinicians should stay aware that what we call remission, blah, 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 is just normal glucose or better glucose control thanks to a treatment. And in the background, until now, we have not found one treatment that can fully protect the progressive failure of the beta cell. Even with bariatric surgery, as you said, there is again a rise in glucose, because even with bariatric surgery, the shifts in incretins, etc., we still have a failure of the beta cell that is progressive. And so what we should avoid is the message to a person with type 2 diabetes? You have been operated, you have had metabolic surgery, you are cured. They're not cured. Their glucose control is now better because of a different treatment, rederivation of their intestine. And so that is really an important message for clinicians. Please explain that to the patient. Don't let them go away after bariatric surgery. You need to follow them up. And messaging and communication is really crucial for us clinicians.
Thank you very much, ma'am. You have given a clear message that how you speak to the patient, the language in which you speak is very important, because they should not go with the wrong idea that things are different. And with this, thank you so much, ma'am. You've given us so many good messages. One last message. What is the message you want to give to all the healthcare practitioners that are listening to this in one sentence?
Do not forget that the person living with diabetes in front of you, sitting in front of you, is an integral member of the team needed in the treatment of themselves.
Well said, ma'am. Thank you so much. Thank you so much.
Thank you. Bye-bye.
Bye-bye.